field of radiology with key roles in diagnostics, academics, and administration. She's a fellow in Society of Abdominal Radiology and various other societies, has delivered more than 200 lectures and orations, has over 20 research projects funded by NIH and industry combined, and more than 200 index publications, predominantly on ultrasound, thyroid elastography, and obstetric imaging. Thank you for being here, Dr. Manjari, ma'am, and let's go ahead with the lecture.
Good morning, everyone. My name is Manjari Dike. I'm a professor in the Department of Radiology at the University of Washington, and my topic for today is MRI of placental invasion spectrum. My goals for this presentation are basically to review some of the epidemiology, discuss some common findings on MR. We'll look at some pitfalls as well, and then compare the diagnostic accuracy of placental adhesion abnormalities on ultrasound and MRI. And raise awareness of the diagnostic challenge of MRI in this particular diagnosis as such. So the issue is that the incidence of PAS has been increasing over time, and that is associated with the increasing rate of cesarean deliveries. We use ultrasound and MRI for diagnosis of this particular entity, and we use it mainly to help reduce the risk of maternal morbidity and mortality. Now, the etiology or the hypothesis for placenta accreta spectrum is thought to be due to the defect in the decidua basalis, which allows the invasion of the chorion villi into the myometrium. And there's abnormal vascularization at regions where there's been previous surgery and scarring, which can lead to hypoxia, and that leads to the defective decidulization and the excessive trophoblastic invasion. So we'll just talk a little bit about the nomenclature as such. So your pathology can be either accreta, increte, or pacreta. Accreta is when there's just adhesion to the myometrium. Increta is when they invade into the myometrium, and pacreta is when they extend beyond the serosa. And the amount involved could be total, partial, or focal involvement. The previous term used for this particular entity was morbidly adherent placenta. Now, as per the recommendations, the term used is placenta accreta spectrum. So as we talked about it, incidence has increased almost tenfold in the past 40 years. It affects almost 1,200, 1 in 2,500 deliveries. And now, previously, now it's about 1 in 500 deliveries or so. And now in 2020, I think it's increased further and perhaps closer to 1 in 200 deliveries. So the rising incidence of placenta accreta correlates with the global incidence, increase in incidence of C-section rates. It used to be 4.5% in 1965 in the United States. Now it's 31%. And as you can see, the surgery for placenta accreta spectrum can get quite bloody. And that's because of all this, you have to go through the placenta. Next, they have to make sure that once the baby is out, they can get the placenta out safely. And you can see the amount of blood that is lost. So it's not a trivial thing when it comes to surgery in placenta accreta spectrum. So the risk factors, most often it's placenta previa, that can be seen in 5% of cases. If there's prior instrumentation, most often C-section, that increases the incidence as we've seen. And if it increases by 10%, if there's 4 or more C-sections, myomectomy and DNCs can lead to placenta accreta spectrum as well. Now, if both of those are present, that is placenta previa and a C-section performed previously, the risk increases almost 67%. Advanced maternal age has been thought to be associated with an increased incidence of placenta accreta as well. There are some markers that can be used. So these are high AFP, plasma protein A, human placental lactogen, and total placental cell-free mRNA that can be used to evaluate for whether there's a risk of placenta accreta spectrum. Now, prenatal diagnosis is crucial because it allows for planning the optimal time for delivery, the management, and also in terms of future fertility counseling as well. In terms of management, we need to decide the time and site of surgery because this cannot be performed at smaller centers. It needs a bigger center, needs availability of blood products, needs skilled anesthesia, surgical team, even interventional radiologist in some cases, and of course neonatologist to take care of the baby. So in terms of MRI indications of PAS, remember we said ultrasound is a primary modality that is used, but we do use MRI for specific indications, and these include either a posterior or lateral placenta. If the ultrasound is inconclusive or is limited, large BMI patients, high-risk patients, just to get that greater level of confidence and to assess the depth of invasion if they're suspected per crater. So, and we'll see, personally, I think MRI allows for better definition of the abnormal placentation, the modification of the, depth of invasion. You may feel that it is, say, in crater on ultrasound or procrater, and that might change after an MRI. And then it can actually help in change of management as well. In terms of imaging, we like to perform the MRI between 23 and 30 weeks. Sometimes we go up to 34 weeks. As you go beyond that, the placenta ages and evaluation of the features becomes a little more difficult. Supine position, sometimes left lateral decupitated position if the supine position cannot be tolerated. Bladder has to be a little full, not way distended, but at least a little full. We use a surface phased array coil. But you can use a body coil as well. You need a radiologist with expertise either to be at the scanner, or you need your protocol to be well set up and the technologist to have some amount of knowledge when it comes to this particular indication. We use multiplanar T2 weighted sequences in 3 planes, and we do plan in, to the uterine and the placental axis, which may be different from the maternal axis because depending on where the placenta is located, your sag, coronal, axial might be different. We use diffusion weighted imaging. However, the role I think is still under investigation. We don't use a 3 Tesla magnet, even though the safety is now being sort of proven that it's safe. I think there are quite a few dielectric effects, artifacts that are seen, that it becomes a little more difficult to manage on 3 Tesla magnet. Though I think if you have a protocol for 3 Tesla magnet and it's running well, you can use it. Timing, I told you what we do, but you can do it at any time. There's no evidence of increased risk of MRI at any point in gestation. We don't use any gadolinium. And then written and informed consent is important, though there's lack of any data on any effect on the fetus as such. So this is our protocol, as I mentioned. So this is what a normal placenta looks like at less than 23 weeks. It's uniform. It's sort of intermediate signal intensity. You can sometimes see the blood vessels underneath the placenta. These are not increased in size or increased blood vessels. These are just normal blood vessels because remember the placenta is attached to the myometrium. And when you see a nice homogeneous placenta, that can help you have a high level of confidence that there's no placenta crater spectrum. As the baby ages, you can see that the placenta sort of further develops. But it's important, one of the criteria that we use is uterine wall. And it's important to remember that as the baby ages, it becomes a little more difficult to see the uterine wall on MRI because of the stretching and thinning, though it is usually seen as an intermediate and sometimes low signal intensity appearance on MRI. Now, I'd like to talk a little bit about the terminology that is being used. The European work group on placental invasion launched a proposal for ultrasound and MRI descriptors that helps reduce ambiguous terms and standardized terminology. And the hope is that with the standardized assessment, the radiologist as well as the clinicians will be speaking the same language, and that will help benefit future research, clinical care, teaching, etc. So I'm going to use the EWAIP standardized terminology, and these are the different factors that are evaluated in through that particular standardized descriptions. So heterogeneous placenta, so we saw that normal placenta is homogeneous, T2 hyperintense, T1 hypointense, and this is a very subjective sign. So it only has moderate inter-observer agreement, and as a placenta ages and there's hemorrhage, you can have more heterogeneity. But if you don't have that heterogeneity, it does imply less severe form of placenta creta spectrum. So this is what heterogeneous placenta looks like. Compared to a normal homogeneous appearing placenta. You have areas of low T2 weighted signal within this placenta, which appears very lobulated, etc., compared to your normal placenta. The second sign we're looking at is placental bulge. So that is deviation of the uterine serosa from the expected plane, and it is caused by the abnormal bulge of placental tissue into the neighboring organs. So the serosa is still intact, but the outline is distorted. And that helps suggest PAS with a high sensitivity and specificity close to almost 89 to 90%. So this is an example of placental bulge. So you can see that the serosa here, the hypointense line is intact, but the placenta does bulge out. So key here is to look for this hypointense line, and even though we don't see the serosa directly on MRI, that can be a clue that the serosa is still intact. Dark intraplacental bands are one or more areas of hypointensity with a linear appearance, and they're usually in contact with the maternal surface of the placenta. They correspond to fibrin deposition areas, and this is considered to be one of the best features to predict PAS, and has the best inter-observer agreement as well. But it is important to remember that you may see these after 30 weeks of gestation, patients who have preeclampsia and IUGR without evidence of PAS as well. So these are what the dark intraplacental bands look like. So you can see this particular area over here. There's contact with the maternal surface. It does have this geographic sort of stellate appearance. That's because of the plane that we are imaging it in. If you have a cross-section through this plane, you would see it as a single linear structure. So we said this was because of fibrin deposition. You can have false positive appearance of this intraplacental, the dark intraplacental bands, and they can be seen with either infarction, and that's why in normal mature placentas, because as the placenta ages, it does undergo areas of infarction within it. You can have intervenous thrombus or thrombus and hemorrhage, and that can give this sort of an appearance as well. So this is an example. This was a placenta creta in twin A. We could see this sort of dark band in it. And there was thinning of the myometrium, etc. And this patient had placenta creta diagnosed on pathology. Compare that to this particular patient. There's sort of a linear dark intraplacental band, some placental heterogeneity in this particular patient. And it was read by 2 attendings at 2 different times as placenta creta spectrum. But on pathology, there was no placenta creta. There was some severe intrapartum bleeding and lower uterine segment atony. But on pathology, they found that there was fibrin deposition, which was probably because of chronic placental insufficiency. And actually, they could resect the placenta at delivery easily. So here's an example. How do you differentiate between fibrin and versus blood clot? Because that can help you in management. And you can use T1 weighted images. T1 weighted images, when you're looking at dark intraplacental bands, these are not bright on T1 weighted images, but a blood clot would be bright on T1 weighted images. Next feature seen is placental ischemic infarction. There's increased signal intensity on T2, decreased signal intensity on T1, and they result in placental heterogeneity. They usually from venous necrosis, from deficiency of intervillous circulation. They may be associated with preeclampsia and IUGR patients as well. So here's a patient who has ischemic infarction. You can see this focal rounded area of T2 high signal intensity, low signal intensity on T1. We actually did diffusion weighted images in this patient as well. And you can see some restriction in this area on the diffusion weighted images. So loss of retroplacental dark zone. This is the thin dark line that is seen beneath the placental bed. So this is the dark intraplacental, a dark retroplacental dark zone that you can see here underneath the placenta. And it's marked out over here in the yellow dash line as well. So the key here is that this is usually thought to be due to compression of some of the uterine myometrial vessels underneath the placenta as the placentation is happening. It's very non-specific. You may not be able to see it in some normal pregnancies as well. So here's an example where this particular patient in the lower uterine segment, as you follow this dark line in the lower uterine segment, you don't see that dark intraplacental or retroplacental dark zone. And that can be a clue to placenta accreta spectrum. Now, myometrial thinning is seen when the myometrium overlying the placenta thins out to less than 1 millimeters, or it's basically invisible on T2-weighted images. But the issue is that myometrium usually becomes thinner as the placenta progresses, and in areas as the pregnancy progresses, and in areas that have had prior C-section scars as well. So it's very non-specific for placenta accreta spectrum. So you can see in this particular patient, that looks like the normal myometrium, but then as you get over the placenta, you can see that the myometrium is thinned out. And in terms of size, this is definitely 1 millimeter or less in size. So bladder wall interruption, that is irregularity or disruption of the normal hypointense bladder wall. This has high specificity and positive predictive value, but low sensitivity for placenta accreta detection. So what we're looking for essentially is, here's a placenta, there's the placenta sort of extending into the bladder, and you can see this dark line, which forms a bladder wall, along with the surrounding fat, and you can see that it's absent in this focal area. Focal exophytic mass is where there's a break beyond the uterine serosa. So you can see placental tissue protruding through the uterine wall and extending beyond it. And remember, we said that you can see this dark line, which tells you that the serosa is intact, and you don't see it in this particular area. It has a good prediction value for placenta accreta, but does have low sensitivity. Abnormal vascularization of the placental bed, when you see large vessels within the placental bed with the disruption of the uteroplacental interface. So here's an example where you have patient who has thinned out myometrium. In addition, you have these vessels overlying this area. You don't see it on the other parts of the placenta. There's probably a dark intraplacental band there as well at the same location. And so there's disruption of the placenta myometrium interface along with that blood vessels. And this was seen on ultrasound as well. So just a comparison of previously used terms and what the EWAIP wants us to use. Marked placental heterogeneity becomes heterogeneous placenta. There's nothing that describes uterine bulging, but they do talk about placental bulge and in their description. Then all of these terminologies becomes loss of retroplacental dark zone. They don't have anything for abnormal intraplacental vascularity or increased intraplacental vascularity. Don't really talk about tenting of the bladder, urinary bladder. Loss of bladder signal becomes bladder wall interruption, and any of these become focal exophytic mass. So these terms should be discarded, and you should use the recommended terms in order to avoid variability and confusion as well. So a brief description of the new techniques. So diffusion-weighted MRI is something that I mentioned, has been used to detect placental invasion. It started off when this particular paper came out in about 2009. They used a B value of 1,000 and said that they can clearly define the border between the placenta and the myometrium. And the placenta shows very high signal intensity on diffusion-weighted images. So here's an example of diffusion-weighted images, the T2-weighted images, and then the ADC map. And you can see that The ADC map shows higher signal intensity in the myometrium compared to the placenta. If you look at a case that has placenta creta spectrum, this is a normal case. This is someone who had placenta creta spectrum. You don't get that same high signal intensity in the myometrium because it's lost in this particular region, and so that can help in diagnosis. We've actually looked into diffusion-weighted imaging and published a paper on the same, and we found that in isolation, they don't increase the diagnostic confidence, but if you use it in combination with T2-weighted images, that can help increase the diagnostic confidence. So just to sort of look at all these features together, this is a case where the patient had placenta increta. You can see the heterogeneous placenta. You can see the bladder wall interruption. You can see the focal exophytic mass in this particular area. You can see the dark intraplacental bands, the placental bulge with intact serosa, myometrial thinning, and loss of retroplacental dark zone in this particular area. So with the bladder wall, focal exophytic bladder wall interruption, we thought this would be a placenta percreta, but lo and behold, on pathology, the serosa was intact, and so they called it as a placenta increta. This is case 2, where you can see some dark intraplacental bands. There's myometrial thinning, there's placental bulge, and you can see that in some areas you don't see the myometrium at all. And so that's with the myometrial thinning and the overall heterogeneous placenta. This is the explant. So what they said on the explant was that the patient had placenta increta. You can see the bulging over here in the lower uterine segment. And focally, there was an area of placenta percreta. And again, that's on pathology. If you look at the specimen, everything looks intact as they delivered it. Case 3, patient has heterogeneous placenta, quite striking, has some placental bulging, has some dark intraplacental bands, definitely has myometrial thinning. And this actually was a placenta increta, even with the severity that you see in the appearance of the placenta. And they said it was 2 millimeters from the serosa. But again, you can see this bulging of the lower uterine segment, and on a cut section, you can see the loss of the myometrium in this particular region. So in summary, placental adhesion abnormalities can be challenging diagnosis. It does require clinical experience, expertise, and intra-departmental collaboration as well. We talked about some of the MRI features. Most important of those would be the dark intraplacental T2 bands, the placental heterogeneity, normal vascularity, and uterine bulging. However, MRI is not a reliable predictor of depth of invasion. And what I look for is, I almost look for in terms of positive versus negative. What I'm looking for is their extension outside the uterus and involvement of the parametrium or surrounding organs, or not. And then areas of thinning, I report on the worst possible or the worst location, because what they want to know is there involvement of the surrounding organs that they should get other people to help out with the surgery. So basically deciding, how should the surgery be done. Ultrasound is always a first-line imaging modality. MR does add value, in terms of increasing the diagnostic confidence or parametrial extension, knowing as to where the surgical incisions should be placed, are there any large vessels, etc. There's a wide range of reported sensitivities and specificities. I think that depends on the level of experience and expertise as such. It is important to adhere to your protocol, once you have it well set up. So knowing that MRI may not significantly always correctly alter management, but we definitely need more future studies to work on this particular issue. And the management should be based on the worst possible read. So if you decide, so I don't use the terminology accreta, increta, percreta in my reports, but I give more of a descriptive report talking about the worst area as to where it is. If there's different areas showing different levels of involvement, I'll describe that in my report. But the management should always be based on the worst read. These are some references in this particular paper. Thank you very much.
So that was Dr. Manjari Dighi ma'am who took us through MRI placenta. Big thanks to her for sharing this lecture with us. So I have shared the link for registration for the conference in the chat box. So those who haven't registered may please go ahead and do so. I've shared the entire brochure as well for your reference. So we have these 3 days planned for you. Day 1 will be neuroradiology, day 2 will be MSK, and day 3 will be body and oncoimaging. We also have an ortho-radio patho panel discussion and the MR Mania quiz, where obviously there'll be exciting prizes for the winners. So let's move on to our next session, which will be taken by Dr. Deepak Patkar, sir, on MRI of degenerative spine. So, sir doesn't really need an introduction. He is the reason the conference is what it is today. Him and his entire team have brought it to such a level, and I'm extremely thankful to him for providing us this conference. So, sir is the Director of Medical Services and the Principal Director in the Department of Imaging at the Nanavati Max Super Speciality Hospital. He was the past president of IRI in 2020. He has more than 35 years experience in the field of radiology with key roles in academics and administration. He is a member of the external review group for the Rapid Active Guide for in COVID-19 by WHO. He is also a member of the Radiology Advisory Board of WHO classification of tumors. He's been the postgraduate teacher for DNB since 2002. Sir has more than 1,000 lectures and orations at various national and international conferences, more than 163 national and international publications, and he has received the Best Radiology Teacher Award in 2019. So we'll go ahead with the lecture. Thank you.
Gauri, what we'll do in next 25 minutes is, can I have the lights down? Look at how we report MRI with patients suspected to have degenerative spine. What we'll do in the next 20-25 minutes is look at the sequences that we use for degenerative spine, a little bit of anatomy which is relevant to reporting, touch upon degenerative disorders, definition of bulge, protrusion, herniation, etc. Touch upon posterior elements and spinal canal stenosis, and then summarize the whole thing. There are several sequences that are used when we do degenerative lumbar spine. There was a consensus based on ACR, ASNR, SCBT, and MR practices parameter guidelines, which came up in 2014, and that's what we follow. So in cervical spine, we obtain 3 millimeter sections in sagittal and axial planes, both T1 and T2, with a millimeter gap. In dorsal spine and in lumbar spine, it's 4 mm. In addition to that, we do a STIR or FAT-SET T2 sequence. Fat suppressed imaging is very important because of the marrow edema that you look for. So when you have an old patient, typically they will have multiple disc diseases. So multiple disc bulges or herniations at multiple levels, fascial arthropathy. It's important for the spine surgeon or orthopedician to know which one is the symptomatic one. And that can be quite challenging on routine T1 and T2 sequences. So what fat suppressed sequences do is they show marrow edema or disc which is bright, and we know that that is the disc or that is the degenerative end plate change which is giving rise to the pain in the given patient. Nuclear imaging, specifically bone scintigraphy, is also useful to look at which of the disc is the symptomatic one. So what we'll do is we cover a relevant anatomy, as I said, look at anti-elements, that's disc and annulus, two vertebral bodies, that is degenerative end plate changes, and anterior and posterior longitudinal ligaments when they get thickened or ossified or calcified, how they cause canal stenosis. Beyond discs, we look at transition segment, that is sacralization or lumbarization, posterior elements causing disc disorders, typically fascial arthropathy or interspinous bursitis, then understand the definition and concept of spinal canal stenosis, the central canal, lateral recess, and foramen stenosis. And if there is time, we'll touch upon some unusual entities which simulate degenerative disc disorders. I'm not going to go into details of complete spine anatomy, what is relevant when we are reporting an MRI are actual T1 and T2 images and the concept of exiting and traversing the route, because that is what is relevant when you are describing a central disc herniation, paracentral disc herniation, lateral or far lateral disc herniation, and which nerve root is getting compressed or displaced in addition to the thecal sac. So if we look at this axial T2 sequence, axial T2 image taken at L4-5 disc level, in the center you have nucleus pulposus, which contains about 95% water and 5% fibrous tissue. Then you have annulus, which is dark because it predominantly contains fibrous tissue. At L4-5, the disc can be convex or concave. Posteriorly, that does not matter. And we'll understand that concept a little later. This is the thecal sac here. This is superior articular facet of L5. This is inferior articular facet of L4. This is the facet joint. As I said, thecal sac. Just adjoining thecal sac, you have lateral recess. We'll see that in the next slide. And then you have foramen here. You have L5 as the traversing nerve root and L4 as the exiting nerve root. Same thing here, L4-5 disc, thecal sac, traversing L5 nerve root. So this is L5, S1, S2, etc. Superior articular facet of L5, inferior articular facet of L4. This bright thing on T2 is the fluid and cartilage in the facet joint. This is the exiting L4 nerve root. This is traversing L5 nerve root. Same thing on T1 at L5S1 level. So that's nucleus, that's annulus. This is thecal sac. This is exited L5 nerve root. This is traversing S1 nerve root. This is the superior articular facet of S1, inferior articular facet of L5. This is the cartilage in the facet joint, which is not degenerated. So again, thecal sac, lamina, superior articular facet, inferior articular facet, traversing S1 nerve root, exiting L5 nerve root, nucleus pulposus, annulus fibrosus. Lateral recess is defined as an area between the thecal sac and the foramen. So this orange area, which is actually the distance between posterior aspect of end plate of the vertebral body and superior articular facet, this bit is lateral recess and this is foramen. So lateral recess stenosis is defined as a distance between these two getting lesser than 3.6 millimeters. Foramen stenosis, there are no real measurements. Superior articular facet, inferior articular facet, lamina. We'll look at the definition of disc degeneration, bulge, protrusion, herniation, sequestration, etc. If you look at literature again, there are several classifications available and some reports describe disc, bulge, protrusion, herniation into 6 subtypes. That gets too complicated and it becomes too measurement-like. The simpler version of defining disc degeneration is broadly divided into 4 subcategories: a simple disc bulge versus herniation, and acute versus chronic disc, and soft versus hard disc in the cervical spine. And we'll understand this concept in next few slides. As the nucleus degenerates with aging or chronic microtrauma, the water which I said is, which is 95% in the nucleus, starts getting lesser and lesser, and the disc gets lesser and lesser bright on T2. With that, the inner annular fibers or Sharpie's fibers start getting ruptured, and the outer annular fibers start getting bulging beyond the end plates of superior and inferior vertebra. So when it happens circumferentially across the board, it is called as circumferential bulge. When it happens in an area which is more than 25%, it is called as asymmetric bulge. When it is less than 25%, you have what is called as this protrusion or herniation or extrusion. So here are two examples of these degenerated L4-5 and L5S1 discs. At L4-5 disc, if you see, there is extension of nucleus beyond an expected area of annulus. And it's across almost 70 to 80% of the disc contour. So this is called as circumferential bulge. If you look at this L5S1 disc, this bulge is asymmetric but diffuse. So this is called as diffuse bulge, and this is minimally indenting thecal sac and causing mild foraminal as well as lateralis stenosis. Compare foramina and lateralis here versus this. Here the lateralis and foramen contain fat and then normal. This protrusion is defined as this protrusion, which is the part of herniation, when less than 25% of this circumference gets out of the boundary of the upper and lower vertebral bodies. When the apex of the disc herniation is smaller compared to the base, it is called as protrusion. And here are examples. So here L4-5 and L5S1 discs are degenerated. There is herniation of this L4-5 disc, which has broad base and relatively narrow apex. So this would be described as broad-based right paracentral protrusion of L4-5 disc. What it is doing is it is compressing the thecal sac and right L5 nerve root, which is trapped here. This is the normal left L5 nerve root. Compare this with disc extrusion, where base of the herniated disc is narrow and apex is broader. And here is an example. So if you see this L4-5 disc, the herniated disc has broad apex, narrow base. Same thing here. Narrow base, broad apex. So this L4-5 disc herniation would be described as right paracentral extrusion of L4-5 disc, causing compression of thecal sac and right L5 nerve root. This is the normal left L5 nerve root, and these are exited L4 nerve roots. If you see here, there is a lot of degeneration of the nuclear material. Compare this with this normal L3-4 disc. When the herniated disc fragment separates out from the parent disc, like in this case, it is called as sequestration. And then the sequestered disc can go down or up, and then that is described as superior or inferior migration. And here is an example of a person who has multi-level disc herniations. However, at L3-4 level, what has happened is the nucleus has separated out from parent disc and has migrated behind L3 vertebral body. So this is T2, T1. Post contrast, we are getting peripheral enhancement of this sequestered disc, which is lying in the left lateralis. So this disc herniation will be described as left paracentral extrusion of L3-4 disc with sequestration and superior migration. In terms of how they are described in location, whether it is central, paracentral, or foraminal or extraforaminal, is based on axial images. When the disc herniation is in the center, it is described as central. When it is in the lateralis, it is described as lateralis herniation or subarticular herniation or paracentral herniation. When it goes at the level of foramen, it is described as foraminal herniation. And when it goes beyond the margin of foramen, it is called as extraforaminal herniation. And we'll say examples of all these 3 or 4 entities. Here are 2 different patients. This patient has more or less central herniation of this L5S1 disc. What it is doing is it's causing compression of the thecal sac and right S1 nerve root. This patient has relatively focal right paracentral herniation of L4-5 disc, which is compressing thecal sac and the traversing a right L5 nerve root. The lateralis is narrowed here. Foramen is free. Here is a patient with lateral or foraminal disc herniation. If you look at these keyholes, which you normally see, keyhole at L4-5 level is obliterated by this disc herniation, which is in the foramen again. And the keyhole, as I said, is narrowed in the left foramen. So how this will be described as left paracental and foraminal herniation of L4-5 disc causing left lateralis and foraminal narrowing. Also, there is fascial arthropathy, the concept of which we'll understand little later. So this, as well as fascial arthropathy, have caused foraminal narrowing at L4-5 level in this patient. When the disc herniation goes beyond the foramen, like in this case, it is called as extraforaminal disc herniation. And describing this is very important because approach for surgical removal of this disc is extraspinal, which the surgeon would like to know. So that is about disc disorders and their definitions and how you report that. In addition to disc disorders, you need to see the changes in the vertebral end plates also, which are evoked by degeneration of the disc. And these are defined by Modic into 3 types. The first one, grade 1 degenerative end plate changes, are basically due to presence of marrow edema, which is caused by this degeneration and rupture of annulus along the end plates. So initially there will be inflammation of the end plates, which appear dark on T1 and bright on T2 and stir. In the next stage, the normal red hemopoietic marrow is converted into yellow fatty marrow because of marrow ischemia that happens. So if you see here, you have end plates as bright on T1 and T2 both, indicating type 2 degenerative end plate changes of Modic. Third is the stage which is seen on X-ray, which represents sclerosis. So if you see this patient who has severe degeneration of all the discs, has type 2 fatty marrow changes at L5S1 level and type 3 sclerotic changes at L4-5 level. In addition, there is degenerative anterolesthesis and interspinous bursitis. Anterior and posterior ligaments, posterior longitudinal ligaments can get calcified or ossified as a part of degeneration, and they are more common in the cervical region and are associated with DISH, which is basically sclerosis, which happens along the anterior margins of the vertebrae. Diffuse idiopathic sclerosis, which happens along the anterior margin of the vertebrae, but it can also happen along the posterior margin of the vertebrae. And here are 2 patients showing ossification of posterior longitudinal ligaments from C2 to C5. If you look at axial T2 images obtained through mid-vertebral body level, there's something that looks like this herniation, which is actually ossified posterior longitudinal ligament. Another patient showing ossification from C2 to C5, very well seen on CT as interrupted ossification of posterior longitudinal ligament. These are also associated with disc protrusions at multiple levels. And in this particular case, there is severe canal stenosis with cord ischemia from C3 to C6 with severe secondary canal stenosis. So that is about anti-elements and their degeneration and description as to how to describe them. We will now look at associated changes which happen in the posterior elements as well as a part of this degenerative disorder. The commonest things that happen along with this degeneration is facet joint degeneration. So facet joint is actually a true synovium-lined diarthrodial joint which starts degenerating as early as second decade of life because of chronic microtrauma. So every time you turn, bend, sit, or have odd postures, there is pressure not only on the discs, but also on the facet joints. So they start degenerating. The cartilage and synovium between the two superior and inferior articular facets start getting degenerated. And almost 100% of population beyond the age of 60 years has some amount of fascial arthropathy. If you look at 100 patients with backache, almost 15 to 30% of this population will have mechanical axial low back pain because of fascial arthropathy more commonly than pure disc disorders. The first stage of fascial arthropathy is inflammation, and these patients present with morning stiffness, tenderness, which increases with rotation or extension of the back. And typically on FATSAT T2 or post-contrast FATSAT T1, you'll see a lot of inflammation around these degenerated facet joints. So osteoarthrosis in facet joints can be mild, moderate, or severe. There are no defined criteria for that, but what we look for is erosions along the articular cartilage of the joints with large geodes or cysts. You get periarticular hyperostosis. In fact, the ligamentum flavum also can get calcified in the lower lumbar region. You get joint space narrowing and erosions and geodes, as I said. You get subluxation of the facet joints with anterior listhesis and hypertrophy of ligamentum flavum. In the real advanced stage, you can get intra-articular bony fragments and intra-articular gas or vacuum phenomenon. Synovial cyst formation also happens because the facet joint has no capsule anteriorly. So the synovium, which gets inflamed, extends posterior to the ligamentum flavum, causes degeneration of ligamentum flavum, like in this case, and that leads to distension of the joint space and synovial cyst formation. So here, if you see thecal sac is getting compressed by a large synovial cyst. At times, the synovial cyst is pseudo because it is covered by fibrous tissue and not covered by synovium. And it can contain clear fluid, like in these two patients, or it can have hemorrhagic fluid or calcification as well. So that is about facet joints. Along with facet joint degeneration, degeneration of ligamentum flavum also happens. So ligamentum flavum is basically a yellow elastic tissue which preserves upright posture of ours, and it assists the vertebral column in resuming posture after flexion. So as you bend and try to extend and come back to normal posture, ligamentum flavum comes into picture. Laxity of this ligament typically happens because of facetal arthrosis with alteration in the biomechanics. So initially you get edema like this, you can get inflammation, eventually calcification and bony proliferation. Coming to pars interarticularis, this is one thing that you can miss on MRI if you don't have a look at X-ray. CT very easily identifies the break in pars interarticularis, but most of the times we do not do CT. So what you should be looking for on FATSAT images is increased T2 signal adjoining the pars interarticularis. This would almost always correlate with patient's pain intensity. So right-sided pain, you'll find right-sided lysis. If there is edema bilaterally, patient will have central pain. Coming to Bastard's disease or kissing spine or interspinous bursitis, as it is called, it is often missed because we tend to look at discs and facet and forget to look at interspinous spaces. So if the patient has exaggerated lordosis, the gap between the spinous processes of lower lumbar vertebrae reduces. So this is the normal gap. If you see here, it has significantly reduced because of exaggerated lordosis. They start bumping against each other, especially in extension position, and then fluid accumulates in the bursa between the cysts, and they can get quite inflamed and cause intense pain and inflammation. This typically gets relieved when patient bends or has forward flexion. Coming to transitional segments, a lot of us ignore the transitional vertebra. If you look at literature, they say almost 30% of the normal population will have transitional vertebra, which means typically this vertebra will have features of both lumbar and sacral vertebral bodies. Most of the times they are asymptomatic, but depending on how the morphology of sacralization is, you can have pain. And typically it happens because of pseudo-neoarthrosis, which happens at the lumbosacral junction that gives rise to pain. Sometimes you can get nerve root impingement and degeneration of the last mobile disc. Segmental instability or listhesis, forward listhesis as well as backward listhesis, is caused by several factors. The commonest, of course, being disc, but it can also be caused by fascial arthropathy or ligamentum flavum arthropathy, ligamentum flavum hypertrophy. Anterior listhesis is typically caused by facet joint arthrosis. Posterior listhesis is caused by degenerated or herniated disc. Scoliosis causes lateral listhesis, and asymmetric fascial arthropathy, unilateral fascial arthropathy, will cause rotational listhesis. And here are examples. This patient has severe fascial arthropathy at L4-5, which you can see, with some interspinous bursitis. This has caused anterior listhesis. Typically, degenerative anterior listhesis is, it remains up to grade 1. When you have more than that, grade 2, grade 3, or grade 4 listhesis, it is almost always associated with wide canal sign, and then you should be looking for lysis at that level. This degeneration usually causes retrolisthesis. So if you see more retrolisthesis, it is caused by degenerated disc. If you see more anterolisthesis, it is caused by fascial arthropathy. Let's now look at spinal canal stenosis and its definition. As Malini said, these measurements are not really useful in a given patient. Most of the spine surgeons would ask for this because you can use that as a baseline to decide what the patient has. Primarily, the neurological codification is what the surgeon should be looking at rather than looking at absolute measurements. Problem with absolute measurements is in the given patient, patient's height would be different, patient canal structure would be different. Typically, when the anteroposterior distance at mid-vertebral level is less than 10 millimeters, it is caused as definite canal stenosis. Anything more than 12 is normal. Something between 10 and 12 is considered in lumbar spine as borderline canal stenosis. In the cervical spine, you have to reduce both the distances by 1 mm each. So anything less than 9 is abnormal. Anything more than 11 is normal. Lateral as we saw, anything less than 3.6 is considered as abnormal. A lot of people take help of measurement of area at each level. So anything less than 75 millimeter square is called a severe stenosis. Anything more than 100 is considered as normal. Canal stenosis can be congenital, which is called a short pedicle syndrome. It can be acquired because of several reasons, including disc disorders, fascial arthropathy, ligamentum flavum buckling, or malalignment. What we look at is not absolute canal measurements, but the shape of the canal at this level. So trefoil shape is what you should be looking for, along with complete loss of epidural fat and relative overgrowth of facets or ligamentum flavum, thickening or pseudo-thickening or hypertrophy. So if you look at this patient, if you look at the canal, it is nice and round. The thecal sac is nice and round. Here, because of bulging disc, fascial arthropathy, and ligamentum flavum thickening, it has become triangular or trefoil shape. So these are two extreme examples. Typically in practice, you'll see something in between, and you'll have to call it as mild, moderate, or severe stenosis. At foramen level, again, the narrowing of foramina is caused by hypertrophied facet, synovial cyst, ligamentum flavum hypertrophy, or it can be caused by foraminal disc herniation. So if you look at these foramina, these are nice and wide. If you look at these foramina, the normal keyhole shape of the neural foramen is lost. So this is moderate stenosis where you can see a little bit of fat in the foramina. This is severe stenosis where you virtually see no fat in the foramina. So this is how you report a patient suspected to have degenerative spine. Look at these disorders, which are divided into bulge, protrusion, extrusion, and then you look for whether it is superiorly migrated, inferiorly migrated, sequestered or not. Sequestration, always look for the disc which is ruptured, the nucleus which is ruptured, the annulus which is ruptured and nucleus coming out, and where it has gone. Look for associated degenerative end-plate changes. Facet joint arthrosis will be almost always associated with severe disc disorders unless you are dealing with a young patient. Look for synovial cysts because these are very often missed. They're never as bright as you see here. They can be subtly bright. Look for facet synovitis, a lot of inflammation that happens in acute fascial arthropathy. Look for ligament of flavum hypertrophy, pseudohypertrophy, or thickening. Never forget to look at interspinous presses. Many times, especially when you have exaggerated lordosis, because these spinous processes are abutting against each other, there'll be inflammatory bursitis at this level. For transition segment, always do whole spine screening because especially if the patient is going to undergo surgery, reporting of exact level is very, very important. Anterior listhesis caused by degenerative disc disorders, posterior listhesis caused by fascial arthropathy. So to conclude, knowledge of anatomy is the key to precise understanding of pathophysiology, which is associated with degenerative disc disease, as well as its accurate description is very, very important. MR, with its potential of depicting intricate spinal anatomy in details, is, we all know, the cornerstone of minimally invasive spinal surgeries. Being immensely relied upon by everyone, each and every possible detail needs to be understood and reported, not only the disc disorders.
Thank you, sir, for this wonderful lecture. Next, we have the MRI quiz by Dr. Mitusha Verma, ma'am. She is a consultant radiologist at Nanavati Max Super Speciality Hospital with special interests in body imaging and advances in radiology. Ma'am is a core committee member of the IRIA as well as the state chapter, and she's also a member of RSNA ESR BIR. Mitusha ma'am is co-guide for postgraduate DNP radiology students. Ma'am has several presentations at national level as well as in the ECR 2016 and RSNA 2018-19. Mitusha ma'am has won various honors and awards. The one which is leading young radiologist, radiology and imaging excellence awards, as well as Women Icon Award Feb 2020. So now we have this MRI quiz, and the quiz winner is going to be, will have a free registration at the MRI conference.
Thank you, Pooja, for the kind introduction. So before we move ahead to the next talk, which is going to be by Dr. Malini Lavande ma'am, we'll have a short quiz. And the rules are very simple. So there'll be 10 questions which will be shared. They are like very simple questions. And the last three are the prize winning questions. So you have to just simply write down the answer on the chat box